Good evening, everyone. My name is Gladys Pryor, and I am the co-director of the Office of Community Engagement and Diversity for the Department of Molecular and Human Genetics at Baylor College of Medicine in Houston. Welcome back to Evenings with Genetics, which is a free seminar open to the public. During the webinar, you can enter questions in the Q&A box at the bottom of your screen. Today we have a special guest, Christina Miyake, and Dr. Chaya Murali, who is an assistant professor for the Department of Molecular and Human Genetics here at Baylor, will moderate the discussion and questions. So Chaya, would you like to take it away?
Yeah, certainly. Thank you, Gladys. So I'll take a couple minutes to just introduce Dr. Miyake, who we're really excited to have here today. Dr. Miyake is an associate professor and is the director of the Cardiovascular Genetics Arrhythmia program at Texas Children's Hospital. She's also a member of the Arrhythmia and Pacing Service at Texas Children's Hospital. She specializes in the care of pediatric and adult congenital patients with cardiac arrhythmia disorders. Dr. Miyake is also an associate professor in the Department of Molecular Physiology and Biophysics at Baylor College of Medicine, and she's actively involved in basic and translational research with a particular focus on identifying the genetic and molecular basis of heritable arrhythmia disorders. And I can say from personal experience, she's been a wonderful colleague to work with on many interesting cases. Her long-term goal is to leverage her clinical, basic, and genetic expertise to advance treatment and improve the quality of care and outcomes among patients with arrhythmia disorders. Dr. Miyake is dedicated to her patients and the care she provides, and she continually strives to advance the field to improve the quality of care and outcomes for all patients with arrhythmia disorders. So Dr. Miyake, I'll let you go ahead.
All right. Thank you so much for that introduction. And thank you to everybody who's here tonight to listen. I'm going to go ahead and share my screen. So I was asked to speak about arrhythmia syndromes, and I wanted to open the slide. Some of you may have heard an earlier talk today. You'll see some of the similar slides, but I really want to share these stories of these children and families. This is Jaden Bowner. She is 7 in the picture. She first fainted at the age of 6. She was at a water park and had to be pulled out of the lazy river where she had been tubing. At age 7, she collapsed in a bathtub and started seizing. 1 week later, she suffered a cardiac arrest. I met Jaden in the cardiac ICU where we made her diagnosis shortly before her death. Her mom asked me to share her story, and hopefully by the end of this, you might actually be able to make the diagnosis yourself. So my goal is to provide a very basic review of the heart and its conduction system. And the reason I want to do that is just to kind of help you understand why genetic changes in the channels that are part of the heart and receptors that are in the heart lead to arrhythmia syndromes. And then I'm going to use real life clinical cases of patients to discuss 3 of the most common of these heritable or arrhythmia disorders that can be passed along in families. I'm going to discuss some of the signs and symptoms, what to look for, how we make the diagnosis, some really basic management, but hopefully what I can do is share the stories of families who have suffered unimaginable loss, but also the survivors who survived thanks to early diagnosis. And so here's just a basic review. And again, I know I've got people on here who are physicians and I've got parents. I'm going to try to explain this in a way that hopefully makes sense. The heart's job is really just to pump blood. It needs to pump the blood. It is vital to make sure that it gets blood to all of your organs and importantly to your muscles, to your brain. It's what makes everything function. In order for your heart to pump, it has to know when to pump. And it does that through the electrical system. So I also often think of the heart as a house. It's got your walls, it's got structures, it's got rooms. But in order for your house, for the lights to work on your house to function, you need the electrical wiring to work. And the electrical wiring can be hard to see because it's hidden in the walls. So you need special testing in order to look at the electrical wiring. And what you're going to see is that a lot of the diseases I talk about today are part of the electrical wiring of the heart and difficult to see unless you do specific tests and you really know what you're looking for. So in this diagram, the conduction or the electrical system is shown in yellow. These do not contract. The pink part of the picture are the heart cells, and these are what contract. So the yellow cells need to get the information to the pink cells to tell them to contract. And how do they do that? Well, electrical signals flow because ions flow in and out of the heart and between the heart, and they create what's called an action potential. That action potential is shown in the far right, and this single action potential will create one heartbeat. When all the electrical signals flow through the heart in the right manner, then it will allow the heart to beat one time. And so you can see that single beat on an electrocardiogram. And so you'll see that electrocardiogram down here. That's when your child or gets an EKG. This is special testing where we're looking at the wiring of the heart. And so if there's a problem with the action potential, you typically will see it within the EKG. So it is a picture or a snapshot of the electrical system of the heart. And each beat allows the heart to contract. This is just a picture or a diagram of that action potential I talked about. You need this for your heart to beat. And there are different phases of this action potential that are needed in order for the heart to beat. And for each phase of the action potential, each phase is occurring or starting because ions are going into and out of the heart cells. These ions are depicted by these letters, sodium, calcium, and potassium are the major ions that need to go into and out of the heart. And in order for them to go into and out of the heart, they go in and out through channels that span the heart cell membrane, so they can go in or out. And so SCN5A is the gene that encodes the channel that allows sodium to enter and exit the heart. And KCNQ1 and KCNH2 encode the channel for potassium. In gray for those physicians are two other genes that we won't talk about, but they also cause rare diseases that cause arrhythmia syndromes. So we have these ions moving into and out of the heart, and we have electricity moving through the heart. But how does that actually get your heart to pump? So let's go through this. In one of the phases, in phase 2, a little bit of calcium is going to enter into the cell. And that, once it enters into the cell, it's going to bind to a receptor called the ranitidine receptor. And this is also a gene that encodes this protein. The binding of a small amount of calcium by the ranitidine receptor allows a release of a large amount of calcium into the heart cell. That calcium binds to the heart muscle architecture that allows the heart to contract, and that's where you get your heart to beat. So there is a coupling of the electrical wiring flowing through the heart to then couple to the heart beating. So it's two different things going on that allow the heart to beat. And so again, we've got the heart, we've got the electrical system moving through the heart that allows the heart to beat. The electrical wiring is creating an action potential that tells a signal or tells the heart when to beat. Anything that's a problem with the action potential or the ions that are involved in this action potential, we typically will see problems on the EKG. But that's also coupled to the ranitidine receptor that is coupled through phase 2, and anything over here may not be seen necessarily on a baseline EKG. In this picture, I show you all the different genes that are involved in the diseases we're going to talk about today, and we'll come back to this picture several times. The other thing that's important from a genetic standpoint is that whenever you have a gene, and there's a problem with that gene because it creates a protein that's important in the heart, it can either be a problem because it's loss of the function. In other words, that ion channel doesn't allow ions to go in and out because it's blocked, it's losing its function, or there's a gain of function, meaning that channel is kind of doing more than it should. It's allowing more ions to go in than it should. So depending on your genetic change, you can either have a gain or loss of function of that ion channel, which could potentially create different diseases, even though the same gene is and has a problem. All right, so now with that background, very, very basic review of the electrical system, the importance of it, let's go into some cases. So this is Sandy. Sandy is a 13-year-old female, and she has a history of seizures since she was 5. She's followed by neurology, and she's on anti-seizure medications. When asked, her mother tells us that her seizures occur mostly in the morning when she comes to wake up Sandy for school. They've been increasing for the past few months despite adequate Depakote levels. That's the anti-seizure medication she's taking. They last about 20 seconds and then she urinates on herself. But she's back to herself really quickly. She doesn't have a typical, what we call post-ictal state. That's a confusion, a period after a seizure where a child takes a while to get back to themselves. Well, Sandy doesn't have that. One day, she's at school, she falls out of her chair and she has a seizure. And that brings her to the emergency room. Well, in the emergency room, they actually decided to keep her and admit her, and that's because her heart rate was a bit slow. So she gets admitted to our service, or actually to the pediatric service, a general service. And because her heart rate was slow, they put her on special monitors. If you've ever been in the hospital, you can be put on special monitors, and that monitors your heart rate the whole time, or the rhythm. In the morning, as in any teaching hospital, a pediatric resident came in to examine Sandy for rounds. And when he did the exam, he listened to her heart and he put his cold stethoscope on her chest, and it startled her from sleep. Her waking up from sleep was captured on the telemetry, or the rhythm monitoring service, and they alerted our team because we follow the rhythm. And what they saw was a specific rhythm. So what you see, instead of a nice even beat, this is a normal heartbeat. What you see is an erratic, really fast. This is the heart beating so erratically and so fast that it's not pumping blood adequately into the body. This is called torsade de pointe. It's also called ventricular tachycardia, a special name for when the ventricles, or the bottom chambers of the heart, beat abnormally and too fast. This is what either causes you to pass out or can kill you. So this is Sandy woke up and she's fine. We get an EKG on her, and an EKG, again, is a picture of the electrical system, and the electrical system needs to flow in an appropriate time and manner. We make measurements on the EKG. So what you can see here, I'm circling after this heartbeat, I already showed you, after the action potential, here is something called the T wave. And the T wave has a measurement that we make on our EKG. It's made by every computer, and it normally measures less than 450 milliseconds. If it's over 500, it's concerning for a disease called long QT syndrome. Sandy's was 565. That's putting her at incredible risk for a life-threatening event and concern for long QT syndrome. So we sent genetic testing for long QT syndrome for Sandy, and her test came back positive for a pathogenic, or a real deal gene change in a gene that's known to cause long QT syndrome. And hers was in KCNH2. We talked about that's a gene that encodes the potassium channel. So there's a problem with Sandy's potassium channel, which is causing her abnormal rhythm. So this is syndrome number 1. And if you as a parent, one of the things, if you don't have a child that has this, one thing is it's pretty common. So you might hear a story, you might help another parent recognize this and maybe direct them to appropriate care. It's estimated to affect 1 in 2,000. It is autosomal dominant, meaning that it's passed along in families. If one parent has it, there's a 50-50 chance that their child will have it. There are 3 main types of long QT syndrome, 1, 2, and 3, and it's characterized simply by that picture on the EKG, that QT prolongation I showed you. Otherwise, the child is completely otherwise normal, healthy, you wouldn't know. And then sadly, these are some of the stories that you hear on the news where a young child, otherwise healthy, might collapse on a basketball court, the football, or perhaps oftentimes during exercise. The most common symptom is fainting, we call syncope, or cardiac arrest due to torsade de pointe. That's that rhythm I showed you. It's life-threatening if it doesn't stop. The trigger for these events or for the rhythm depends on the genetic change that you have or the type of long QT syndrome you have. So if you pay attention to this, if you ever hear a child who's having fainting or syncope or events, think about when it's happening, because the trigger for long QT syndrome is usually swimming or exercise. In long QT type 2, it is fear or loud noises, alarm clocks, or startling it, particularly in the morning hours. So if you remember Sandy, every time she get woken up by her mom in the morning, this is when she would have a seizure. Again, when the pediatric resident put his stethoscope on her chest, woke her up suddenly from sleep, that's when she had the torsade de pointe. Fear or anxiety can also do it. If she was sitting in school, anxious about a test, this can also trigger it. If you're pregnant around peripartum, that means around childbirth, it's also a trigger for females. In long QT type 3, the trigger is sleep, sadly, but it is the least common form of long QT syndrome. So again, here's our diagram. We went back, we talked about the electrical system, and I showed you the genes. In long QT syndrome, it is these two genes, or these three genes, within the action potential, and that's why you see the change in the EKG with that prolongation of the QT. Long QT can either be caused by a loss of function or a gain of function of the channel. So let's go through a little bit again. Why in the world do these otherwise healthy children suddenly collapse, faint, or die? They're born with a DNA change. They could have inherited it from a parent, or it was just them. It started with them. And that DNA change results in the recipe for a defective protein or ion channel in the heart. I told you that channels are important for allowing the ions to go into and out of the heart to allow the electrical flow to work. Well, they're born, the channel's defective. And here's an example of the potassium channel. It's defective in this part of the action potential in phase 2 and 3. And that defective channel, which blocks potassium from exiting the cell, means it takes longer for the cell to get back to normal. That prolongation in that phase leads to changes on the EKG. And for us, it's the QT prolongation that we see, and that's showing us signs that the potassium channel is not working. When that QT is prolonged, this is the problem, and it can lead to this torsade de pointe, or this life-threatening arrhythmia, which, if it stops, causes fainting. If it doesn't, it causes death. So let's go back to Sandy. Remember, her seizures occurred mainly in the morning when her mother woke her up from school. They've been increasing. They last only 20 seconds, and she's back to herself without this typical state that most kids with seizures, or kids with seizures, will have. And that's because the brain, when there's a seizure, oftentimes many of the generalized where the child is fully shaking, if it's a brain problem, it takes them a while to recover. That's not all seizures, but the ones where the child is entirely conscious and fully shaking, they generally will have this postictal state. So we ask specific questions. When a child has a seizure, we need to kind of differentiate whether is it a seizure, a brain problem, or is it a heart problem. We often ask specific questions. How long did it last? If the seizure is from a heart rhythm problem and the child wakes up, then oftentimes the rhythm isn't as long as maybe a seizure might be. And that's because the brain isn't getting oxygen, and that's why the patient's having a seizure. It's not because it's a primary brain problem. Seizures that don't have a postictal state, that rings a red flag for a possible heart rhythm problem. And arrhythmias that are related to seizures are often so if it's an arrhythmia rather than a brain, it can often be provoked. There might be a trigger, for example, for it. So if the seizure is occurring in particular instances, when the child's excited, when the child is fearful, then it's a red flag, and you should think about a heart-related condition rather than a primary neuro in your differential. Doesn't mean it isn't, but it's something you should think about. So what's the basic treatment for long QT syndrome? It's the most common. The thing about long QT syndrome is a very treatable disease. If you can diagnose it, then there's a very good chance that your child, the family, can live a normal life. The primary treatment is medications. It's a beta blocker, but you also need to know that certain beta blockers are better than others. So you want to get to someone who really knows about long QT syndrome, who kind of gets that treatment on for the right medication for the right type of long QT syndrome. Lifestyle counseling is really important. So these children can live normal lives, but they just need to be counseled to avoid their particular trigger. So if you have long QT syndrome type 3, for example, you're not as at high risk for exercise as you are if you're long QT type 1. So you want to make sure that you know what type your child has, or the patient has, so you can counsel them appropriately. So you're not withholding certain things that can really affect a child's mental health, and what they can do. You don't want a child who is out there fearful of everything. That's an important part of our counseling. The genetic counselors, if you're out there, this is a really important part in how you help us and the families. A sympathectomy is something that we can do. A sympathectomy it's where you cut the nerves that lead to the heart. It's not as scary as it sounds. It's actually a pretty minor procedure, but the nerves actually innervate the heart and release adrenaline. And so we can actually block the adrenaline input into the heart, which helps prevent some of these events. An ICD is an implantable cardioverter defibrillator. It's a device that you can implant into a patient. So they're walking around with a shock paddle. If it ever recognizes that torsade de pointe, it can shock the patient back to a normal rhythm. If you are a parent, or if you're a family, knowing CPR and knowing where the AED is can be important because that can save a life. Psychological counseling is also a very important part of our treatment. In any program, it should be, because these diseases really affect not only the child, but the family caring for them. Fear of dying is very, 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 it's detrimental to always feel like that. So it's an important part of our care to make sure that they seek help, and that's part of their of medical treatment. All right, so let's go back to Sandy again, and why genetics is so important, and recognizing it, whether you're an adult or you're pediatric, that we help each other treat these families. So we diagnosed Sandy with long QT syndrome. She has a pathogenic variant. It turns out that when we were taking the pedigree, her mom disclosed that she herself had an ICD. In fact, she'd had it for several years. She didn't know why she had it. No one had, she wasn't sure. She went into the ER because she was dizzy, and she came out with an ICD. So she actually ultimately, and she thought she had it for a fast heartbeat. We actually were ultimately able to determine that she too has long QT syndrome. And because of that, we were able to diagnose 2 other of Sandy's siblings, or her mother's sons. I do think what's important point here is, if you have a family member who's already been diagnosed, well, then refer those children, make sure that the other family members are identified, because perhaps we could have identified Sandy earlier. And that's an important part of our clinic, is to make sure we identify these deadly diseases before it's too late. So case 2, this is TB, and TB is a 10-year-old male. He's referred to clinic by his pediatrician because of a slow heart rate. His heart rate is 40. He's completely asymptomatic. He just wants sports clearance. Turns out his grandfather died in his sleep at 40, and his father died in a car accident several years ago. This is a slide I took from my genetic counselor, Taylor Beecroft. She gave a talk today, and she make sure to point out that whenever you're taking a family history, we really become not just physicians, but we almost act like detectives, as do the genetic counselors. We really take a look at the whole family, the pedigree, and we're trying to put pieces together to almost solve a puzzle, to make sure we don't miss anything that could be dangerous to the patient that's in front of us. So we're going to look for red flags, things where the family members have died before 50, if they've had syncope or seizures, if they've ever had these events during exercise, swimming, fever, or sleep. We'll explain why later. After emotion, if they've ever had single vehicle accidents, meaning they were the driver, or there's no identifiable cause on autopsy. So with that in mind, let's look at TB's family. His father died at age 26 from a car accident. His grandfather died in his sleep. This had been known for several years. But when we actually did our detective work and asked the family about the motor vehicle accident, it turned out that his father was the single driver. There was no explanation for the accident. He stopped his car in the middle of the intersection. It was after a large meal. He just had a large meal with the family. There were defibrillator pads on his chest at the scene. So we actually, in order to become more of a detective, I actually called his mother in clinic, got the story. It turns out that TB's father also had this event when he was 21. He worked at a meat packing factory and he developed a fever one day. He felt terrible, drove himself to the emergency room, and it turned out that they had to shock his heart into a normal rhythm. They told him that he should go get his heart checked out. Unfortunately, he never did. So that's some red flags already there. When we then asked about the grandfather, it turns out he had this questionable history of fainting previously. He had an MRI with a spot in his brain, which they thought might have caused his fainting or episodes. And he died one day. He went home, got in a recliner, and he was found dead in the recliner at age 54 with no explanation. They thought maybe it was that spot in his brain. So with that, now we're looking at TB, and here's a picture of his heart, his rhythm, and his rhythm actually is abnormal. There's actually no rhythm coming from the top chambers of the heart, and that's really abnormal. The structure of his heart is normal, his echo. We decide to admit him overnight, and this is his heartbeat. So here's one heartbeat. Here's another heartbeat. This is a paper that's going over time. And if you look at the time in which his heart's beating, his heart stops for a whole 6 seconds. Think of that. You have to stop. Your heart really does need to beat. His heart rate was 11. And normal is between 60 to 100. So this is really abnormal. So this triggered us to do genetic testing. We identified 2 genes in SCN5A. One was deemed to be likely pathogenic, meaning, well, it probably is causing some disease, and the other was uncertain. This is one of the things that's really difficult in the genetics clinic, why we have our geneticist and genetic counselors to help us, why you want to go to a group that really does a lot of this, because it can be really challenging. In fact, 0.01% of the population at the time when TB had his genetic testing report done had the same gene. So the question is, well, is it causing a problem in him or not? The literature actually, we identified there are publications with his gene that was uncertain, and we convinced ourselves that it was real. So with 2 genetic changes that we thought were real, we diagnosed, or we felt clinically, that TB had something called Brugada syndrome. And Brugada syndrome is here. It's caused by this gene, SCN5A. It's important for sodium channel. And it was first described in the 1990s. The incidence or the prevalence is about 1 in 5 to 10,000, so less than long QT syndrome, higher in Southeast Asians. It is autosomal dominant, and unfortunately, genetic testing is only positive in 25%. So we're lucky we found something positive in TB. This is more of an adult disease. However, it can affect young babies, so as early as 2 days. But most adults are between 30 to 40 when they have their first event, and it's often during sleep. They can die during sleep. They have events, fainting during fever, after they take certain drugs. Marijuana is one, or large meals. It predominantly affects males, and it can account for 20% of sudden death in structurally normal hearts. Red flags for Brugada syndrome, if you ever hear, is febrile seizures. Now, this is common in young children, but if it persists, if they have fainting or arrest during a fever, if they have these events with use of Benadryl, a drug that triggers Brugada syndrome, marijuana, large meals, Allegra is a common allergy, over-the-counter allergy med, alcohol, and we find these drugs on brugadadrugs.org. The most common symptom is death during sleep. So the diagnosis is made by seeing a particular pattern on an EKG. What's important is that if you ever are getting evaluated for this, or you're a physician, the EKG change isn't always there. You can have an entirely normal EKG because it comes and goes. So that's important. You don't want to get one EKG and have this ruled out. But the EKG changes can be brought out by fever or taking certain drugs. So oftentimes we'll tell parents or patients to get a repeat EKG during a fever. And this is just an example of my patient No changes, no Brugada changes. You would never know that this patient has Brugada. 3 months later, bam, there you go. There's the diagnosis. So our normal EKG does not rule this out. Treatment is fever control. You're going to admit if you can't suppress a fever, you're going to avoid those triggering drugs. We have antiarrhythmic medications if they have arrhythmias. An ICD we talk about, a defibrillator, and there is the ablation. It's a procedure that is currently undergoing clinical trials. So there is treatment. Children can live relatively normal lives. You really got to be on top of the fevers, though. For TB, because of the genetic testing identified 2 variants in him, we ended up putting a defibrillator in him. And during the case, he actually went into this lethal arrhythmia. A code or an event where we had to call in resuscitative help came in. And because we knew his diagnosis, because we knew what was going on, even though we had never seen this in TB before, we actually were able to identify the cause because we actually asked the anesthesiologist, what is TB's temperature? He had a fever, his temperature had gone up, and that's what triggered. We already know fever triggers this. So we were able to address the fever and get him out of this. All right, so let's go back to TB. If you're a geneticist out there, again, it's important. TB was identified to have 2 genes on his genetic test. You really want to know if you are we go as a detective, we're going to go in and try to understand, does he have 2 different variants, 2 different gene changes on or does he have 2 different ones on the same allele? If this might be going a little bit over your head if you're a parent, but if you're a geneticist, this is important because it makes you're clinically more affected if you have 2 genetic changes than if you have 1. So the way we did this is we tested the mom. She had 1 of them. We then tested both of the kids to identify if they might have the other one. That would tell us that his dad was carrying it. One of them had 1, the other didn't. So for that reason, we went and tested the father's sister. She actually did have the other one. So we were able to tell that because of this, the father did have this gene, and TB was at risk because he had 2 genes on 2 different alleles. We went on to do more detective work. We tested the maternal grandmother. She was gene negative. So we therefore were able to diagnose and say that the grandfather had it, and that may have been the cause of his death during sleep. All right, so let's go on. That's Brugada syndrome. That's syndrome number 2. Let's go on to our last syndrome, which is case 3. So this is called CPVT, and I'm going to start by telling you a little bit about this disease so you can understand it before we talk a little bit about the patients. The prevalence is unknown. It's about 1 in 20,000. We think it is autosomal dominant, meaning that if one person has it in the family, 50% chance that a child or a family member could have it. It is the most malignant or most dangerous of all of the inherited arrhythmia disorders that I've talked about today, with a sudden death reported to be as high as 50% by the time you're 30. It's predominantly caused by changes or genetic changes in the ranitidine receptor. I showed you that picture in autosomal recessive. Another form is CASQ2. So let's go over, here's our scheme again. We've already talked about these other genes. CPVT is caused by the ranitidine receptor. So the ranitidine receptor is not part of this action potential. So if you get an EKG, you won't see the changes. So a sport screening EKG is not going to pick up this disease, and that's important. So this ranitidine receptor causes CPVT, and the mean age of onset is really in the pediatric arena. It's 8 to 12 years. And really the other testing is normal EKG, normal heart by echocardiogram, normal MRI. You really got to know what you're looking for to pick up this disease, because the trigger for this disease is adrenaline. So the most common presentation is going to be fainting during exercise or emotional stress, things that release adrenaline. So if you can imagine something where your adrenaline's going to get pumping, this is what triggers the heart rhythm problems that lead to the fainting and the sudden death. Unfortunately, the first presentation can also be death. The lethal ventricular arrhythmias, that's the abnormal rhythm, has a specific form to it. We describe it as polymorphic or bidirectional, that's pathognomonic, and atrial arrhythmias, or rhythms from the top chambers of the heart, are also common. So let's go through and kind of explain, well, why don't CPVT patients always have these symptoms at baseline? Why don't we see it? Well, when they're walking, when they don't have a lot of adrenaline, they have a small amount of release of calcium, this calcium, which is what causes their heart to pump. But if they're running, and that stimulates adrenaline, adrenaline binds in a different way in the heart. It binds to the beta receptors. These are receptors on the outside of the heart. They don't have to do with the ion channel or the action potential. And that beta receptor is coupled, or it's through a pathway. It can lead to triggering of the ranitidine receptor through adrenaline. And when it does in the CPVT patient, because their ranitidine receptor is defective, they get this huge release of calcium in their heart abnormally. And it's that calcium that then triggers all of the arrhythmias in the heart, the lethal arrhythmias that then cause them to either pass out or potentially die. I'm going to show you this in real time. So here's an EKG. Again, the picture of the heart at baseline, completely normal. Each of these spikes is a single heartbeat. So as this person's on a treadmill. Right now he's just standing, but he's going to start running. So, well, now he's walking. So the adrenaline is increasing a little bit. The spikes are normal. As he continues to walk or run, now he's fast walking, the heart rate's going to go up. Then he's going to be told to start jogging. Now, as he jogs, adrenaline goes up. And as you see, there's kind of this weird looking beat. It's not nice and narrow like the other beats. This is that abnormal rhythm that's coming out because of that big release of calcium with adrenaline. And then as the heart rate goes faster, you're seeing more of these abnormal beats. Now there's every other beat. And then as we go farther, there's VT. This is the bidirectional VT, and this is pathognomonic for CPVT. The adrenaline's pumping. Now we're going to tell the patient to slow down. He's going to stop running. Adrenaline's going to go away. And now, boom, it's completely back to normal. So if you're only looking at baseline, you're not going to see it. You've got to get the patient to release adrenaline in order to see the abnormal rhythm and make the diagnosis. So let's talk about Donald. Again, these are all real life cases. Donald is 12 years old. He has a history of seizures since he was 8. He was prescribed anti-epileptic medications, but he continued to have seizures. He was seen in the emergency room because of a head injury, which occurred while he was playing outside. He had been playing, he fell down, he started seizing, but this time he hit his head hard on the concrete driveway, which brought him to the emergency room. He was evaluated by neurology and cleared. His seizures occurred when he was running around, but they also occurred when he was playing video games. It always occurred, according to mom, only when he was excited about the video games. Sometimes when he was running around, he'd fall to the ground, lay there and start seizing, but sometimes when he was laying, he didn't seize at all. He was seen by cardiology and cleared with a normal EKG and a normal echocardiogram. At 3 a.m. in the morning, Donald went to the bathroom, but his cousin was occupying it and they only had one bathroom. As he waited outside, he became upset, anxious, and then embarrassed because he accidentally urinated on himself while he was waiting. He's a teenager. When his cousin came out, he found him seizing on the ground. He called 911. They found him in this abnormal rhythm, ventricular fibrillation. This is the rhythm. They tried to resuscitate him. They were able to get him back and brought him to our ICU where I met Donald and the family. Based on his history, his prior normal cardiac workup, we suspected he had CPVT. Sadly, Donald's care had to be withdrawn due to severe hypoxic injury, meaning that the resuscitation effort just led to a state that it was incompatible. Genetic testing was sent and confirmed he had a de novo or a brand new variant. Only Donald was affected in the family with a ranitidine receptor change. So again, sadly, Donald was diagnosed too late with CPVT. But we wanted to share his story, and we also wanted to tell you there is treatment if you can make the diagnosis. So let's go through treatment real quickly. We told you that the problem is calcium release and that the beta receptor is the problem. So, and this is the rhythm. Well, if you can block the beta receptor, then you can block the adrenaline. That's our mainstay of therapy. We use medications. We also block the adrenaline through a sympathectomy, what I already talked about, through the nerves that innervate the heart, and an ICD as a last resort. The ICD is a last resort because, as you can imagine, if you go into the abnormal rhythm and you shock the patient, it can release adrenaline. And if adrenaline goes along, again, the patient will go back into the rhythm and get shocked again. So it isn't necessarily always life-threatening, although it can be. Or it can be life-saving. I'm going to end with Jaden. This is the girl that I started with. So Jaden was 7. She fainted at a water park. She was in an inner tube, and she was headed toward that big waterfall when she fell out of the inner tube and had to be pulled out of the water. She had a seizure in a bathtub, and then when she got scared. 1 week later, she had a cardiac arrest when her mother showed her a June bug. She was terrified of bugs. I'm sure many of you can probably imagine the same thing that came to our minds as a conclusion as to what might be her diagnosis when she came to our CVICU. She did have CPVT. It was confirmed by genetic testing. Sadly, over the years since I've been here, we've had 15 cardiac arrests from CPVT, and 5 of these children did not survive. So I share these stories today, some of the families, because they're asking me to share the stories. If you ever hear a story like this, if you hear if you can get that child into help or get them diagnosed, I think you can save a life. These arrhythmia syndromes are rare, but they do affect many children and families. As an example, in Houston, there are 2.4 million. Long QT syndrome affects 1 in 2,000. That means 1,200 people are walking around in the city of Houston. Recognizing the signs and symptoms can make the diagnosis and save lives, but you have to know what you're looking for. There is ongoing research into all of these conditions with the hope to find a cure someday. Thank you. And also, if you are a geneticist, there are some programs we are working on to do more teaching and courses. So again, thank you for this opportunity.
All right. Thank you so much, Dr. Miyake, for that wonderful presentation. I certainly learned a lot listening to it. So I'm looking forward to hearing about the questions from the audience. Audience, I forgot to mention this, but you are welcome to put questions in the question and answer box down in the bottom of your Zoom screen, and we'll be able to answer those towards the end there. And we have a guest family to come speak to us about their own experiences with genetic arrhythmia syndromes. And I'll go ahead and let the Burko family unmute and start sharing with us.
So as you can see, we are in a hospital room. So we are newly diagnosed with CPVT, and our story is very different probably from some of the ones you've already heard. Our journey started 5 years ago. And I say 5 because that was the first event that our youngest son had. Our youngest son, Frankie, was jumping on a trampoline at an indoor play park, and he was in one of those games where you're in a harness and jumping on the trampoline. And he had done this many times before and was a gymnast. And he did a backflip, and then he tried a double back, and he didn't quite make the full rotation on the second one. The harness is meant to catch you so that you don't, bump or fall. But apparently, unbeknownst to us, he was not tethered properly. And so it did not catch him when he didn't make the full rotation. Instead, he bumped his head on the soft part of the trampoline. It didn't look too bad when it happened, but it sent him straight. It pulled him or yanked him up. And when that happened, he went straight into a grand mal seizure. That was the very first seizure he had ever had. And my husband administered CPR, paramedics came, and he was transported to the hospital. We spent one night in the hospital, and he was cleared after that. Obviously, we followed up with a lot of doctor's appointments. We saw a couple different neurologists and did lots of testing, and most everything came out pretty normal. From that point forward, they did not give him any medication because they were thinking this might be epilepsy, but they can't diagnose epilepsy unless you've had 3 seizures that are unprovoked, and this would have been considered provoked because of the accident. Following that, a year later, Frankie was, I took the kids to Dave and Buster's, and he was playing a game next to his brother, the one where you're shooting baskets. And each one had their own set of shots they were taking on their own basket. And I was not next to them when this happened. I was across from them. And at one point, our oldest son, Sammy, looked over for his brother, and his brother was on the floor seizing. And he described, he was young at the time, but he reenacted what happened and described it. And what we've come to is we think he had a minor seizure for about 30 seconds. He stood up afterwards, was crying out of fear, but was, for all intents and purposes, fine. We took him to the doctor, followed up with neurologists, and again, we were told that this would now be considered the first unprovoked. They didn't see anything else wrong and did further testing, didn't find anything. About 2 months after that, Frankie, I took my husband and I took Frankie and Sammy to our neighborhood pool. And at our pool, there are lots of things to go on, like slides and high dives and lower diving boards and climbing structures. And when we got there, Frankie had asked my husband, could I go on the high dive? And my husband said, maybe not this time. The high dive is always something that he was fearful of, yet really wanted to conquer. So there were many summers of him going up there, sometimes jumping off and sometimes coming all the way back down. And in this scenario, we got there, told him it wasn't a good idea. And he asked if he could just line up, he and his brother and his friend. And we said, you can line up, because it was a timeout. And the next thing we know, within, 15 seconds, we were putting our towels down and we heard somebody scream, "What's wrong with that kid?" And we turned around, and lo and behold, he was at the top of the high dive. He had gone to the edge of the board. I think he was trying to impress a friend. And, like all kids, good or bad. And he was a very good kid, but we all make mistakes, and he chose to go up there anyhow. When he got up there, we assume he got very scared. He turned around like he wanted to come down. And the reason somebody yelled was because suddenly he was flat on the board, and they couldn't tell if he was messing around or laid down. What my husband and I realized immediately when we turned around was that he was seizing 10 feet up. We took off running because we were only steps away from him. And unfortunately, we couldn't get to him in enough time to catch him. But my husband caught his foot as he was going down. He landed on his head on cement after a 10-foot fall, and somehow miraculously his skull was perfectly intact. There was no blood, and he was seizing. He did wake up though and was confused and crying. On the way to the hospital, I always like to tell people I was told to keep him awake, and I started running out of things to catch his attention. So I started doing times tables because I was out of my mind, not thinking straight. And most people would say, why would you do that to somebody that just fell on their head? But lo and behold, he was answering all of the times tables correctly. So he was, coined the miracle child at Texas Children's Hospital. He made a near complete recovery. He had a fracture in his skull, and he had a bleed. Still at this point, they were right when he came to the hospital after this accident, they went ahead and diagnosed him with epilepsy and started him on Keppra. While we were in the hospital, somebody came in at one point from the cardiac floor, I believe a tech, to take his pulse and his vitals. EKG, and they ended up doing an EKG because this particular tech or nurse was startled by how low and slow, quiet his heart rate was, and then also his blood pressure being so incredibly low. And I told her, I said, it doesn't concern me. It runs in our family. Take mine. And she thought I was kidding, but eventually she really did take mine, and she saw that we mirrored each other. However, I said, this could be a symptom of something. I'm not certain. Can we test further? So they ran an EKG, and that came up normal. Eventually, Frankie was released from the hospital and continued therapy outpatient, and did very, very well. Unfortunately, about 8 weeks, 3 weeks,
3 months later.
3 months later, Frankie was at home and had a wonderful day at school and was upstairs on his phone, talking to friends. He got up from talking to friends and said, "I'll be right back." And he went to the bathroom. He needed to urinate. And we had taught him that if he had what he always described as sort of an aura before his events, that he yell out or sit down or do something to protect himself and alert others. So we heard him from downstairs scream, "I'm about to have a seizure." And then it all went silent and we heard a drop. And so we ran upstairs, and my husband, once again, for the third time, was the first responder and did wonderful CPR on him. The emergency services came, continued to work on him. He was brought to the hospital where they continued to work on him, and they were never able to revive him. What we were told after he passed was that they were just unable, they couldn't understand why his heart stopped. It was unexplainable. I had even asked his team, and his team of doctors are phenomenal. I had asked them previous to this happening, what happens if he has another seizure? He's not fully healed yet. He's really, really close, but we can still see a little bit of the bleed. And they had said, it's just a seizure. It'll be okay. Nothing to worry about. But unfortunately, that wasn't the case. We did do an autopsy after he passed, which came up with nothing. So it was ruled SUDEP, sudden unexpected death and epilepsy. 3 years later, just recently, our 16-year-old son, Sammy, who is perfectly healthy, has never had any health issues, isn't even on any medication, went indoor rock climbing with a couple of friends. And while he was there, he volunteered to go up first after training. They had him harnessed and everything. He had done this maybe once before at camp. He went up, made it to the top of the wall. He loves me to always tell this part. He rang the bell. He made it to the top. And when he did that, everybody that was there, bless you, described it as he rang the bell and his body went limp. And we thought he was playing around or something, his friends did. And so when they realized they couldn't get his attention and he had passed out, or what appeared to be passed out, they slowly lowered him. And somebody there, luckily enough, there was a radiologist that happened to be there with this kid for a birthday party who we didn't know. And he administered CPR immediately. And then the paramedics showed up. Once we were transferred to Texas Children's Hospital, they continued to work on him through this entire time. They were never able to regain a rhythm that would stay. And so they would first, second get a rhythm, and then it would drop out. So they kept working on him and working on him.
Shocked him multiple times.
They shocked him many, many, many times. And then when we got to the hospital, they continued to work on him. We estimate that he was worked on with CPR for close to 2 hours. And at that point, they called it in the ER. They said, "We're sorry." And my husband and I, it just felt like Groundhog Day in the worst possible way, that we were going through this all over again. And we had no idea why. And they said, "We're sorry. He's gone. We're going to give you some time with him." And the whole entire team left the room because he had been pronounced. And my husband and I are standing over our son, and we were, as you can imagine, crying, hysterical, talking to him and praying. And the next thing we know, my husband goes, "Oh my God, he's moving." And I look down, and he's trying to take like agonal breaths. He's going like this. And we scream for the team, and somebody pokes their head in and says, "It's probably just a reflex." And my husband said, I don't. And then all of a sudden, his entire neck turned purple. And then we suddenly start seeing his carotid start going. And we scream, "There's a heartbeat." And the attending runs in all the medical settings we've been in our lives and all we've been through. Never have we ever heard an attending be so shocked that they scream, "Oh, shh." And like the whole team came running in. They obviously stabilized Sammy. transferred us eventually to the PICU. In the PICU, you would think things started to improve from there, and it did seem that way at first. The nurses were very helpful. They were just grateful he was with us. But they eventually came to us as morning started to break, and the attending said, I want to take a moment to warn you and to let you know that it's highly unlikely that he is going to make it through the night. And if he does, he will be severely brain damaged. We're seeing little to no brain activity. The only thing we're seeing is that his pupils are reactive. So with that, I cried. My husband cried, and we looked at him. We said, okay. And I just could not accept that. I just thought to myself, nope, that's not how this is ending. And so I walked back in the room, and we got both of us on either side of our son. We turned on, he is a musician. He's a drummer and obsessive about music. And we turned on his music and put it next to his ear. And we started talking to him. And I whispered in his ear, I said, Sammy, you may not be able to hear me right now. I know you can't, but they're telling us you're not going to make it through the night. And we cannot accept that. You have already defied the odds once, and we know you can do it again. They told us no before. I know you're going to do it. And several hours later, my husband and I were talking to him, and we started to see his eyes moving. My husband noticed it under his eyelids. And they said, and my husband, screamed out again. The attending and everybody were out of the room, and he said, his eyes are moving. And again, we were told it was a reflex. And again, my husband said, well, I think he's responding to my wife's voice. And, they're kind of, okay. And so I keep talking to him, and eventually my husband says, keep talking. And I keep doing that. And it took a little while, but eventually Sammy, the only way to describe this, and this very much describes his personality, Sammy pushed his eyes open. And we screamed, my husband screamed, his eyes are open. And the team started running in. And once again, all over again, it was, oh my God. And the whole team came in. And my husband said to him, Sammy, answer us, by blinking once for yes and twice for no. And immediately he was answering us once for yes, twice for no. Here we are 3 months out from the incident. We're now at tier for rehab. And we've been here for
6 weeks.
6 weeks or so. And
it's been 8 weeks in the PICU and 6 weeks here now.
Yeah, and he's doing exceedingly well. The craziest thing, you've heard a lot of crazy so far, but the craziest thing that I can share with you is that he is fully cognitively sound. He does have some infarctions. When you look at his brain scans, it scared us when we first looked at it, but we're not doctors. And so the doctors looked at it and they were pretty much jumping for joy and said, these are very small markers throughout the brain and he will heal. And we have seen that. So he's had some short-term memory loss. He went from not being able to remember new information, and we would have to repeat every 30 seconds to 5 minutes, to now he's able to hold on to it for hours at a time or plus, just depending. And so his mental capacity is nearly at 100%. What is odd about his case is well, there's so many things, but the most odd thing about his case is that instead of it being his brain that was so deprived from oxygen that he has brain damage, it is his spine. And so he has ischemia in his spine, which is still the doctors don't know yet if that is just swelling or actual damage. But he does have feeling from the belly button down. Some of it is diminished, and they are working to try to help him to walk assisted, which he's been doing a bit of, and we're hoping he'll make a full recovery. But right now, they're unsure. And right now he's diagnosed incomplete paraplegic. and I don't really know what else.
No, thank you so much for sharing that story. Just taking us into your confidence like that. We just couldn't appreciate it more. We appreciate your vulnerability and being willing to help other families like this. And we really wish you the very best, Sammy. We hope you make a full recovery. We're so happy you're here.
Mhm.
Is there anything you want to add
Yeah.
about your own experience?
They kind of hit everything.
Yeah.
From a treatment perspective, though, he's on Nadolol, he's on
Mhm.
flecainide, and he also had a sympathectomy. And we're talking to Dr. Miyake, who happens to be his doctor, about possibly getting an ICD at some point in time.
Okay.
And obviously the hardest part for us and what we're hoping we give you information that will help you, but we're also hoping to gain information in that upon hearing this case, if anything, comes to mind, because we know how controversial the treatment for CPVT is, and more specifically ICDs and CPVT. And so these are some really difficult decisions that we have in front of us.
Yeah. If I could ask one question to y'all, and then we'll open it up to the other folks. I get to be selfish because I'm a panelist. You had mentioned that you yourself had some history. Was it seizures or something?
So I sort of skipped around. So eventually with Sammy, he was genetically tested at TCH,
Right.
and when he was tested, they also tested Craig,
Mhm.
Frankie. They still had genetic material of Frankie, so they were able to, thank goodness,
Yeah.
test Frankie's genetic material and mine.
Mhm.
And what we learned from that and testing extended family like my parents is that Sammy, Frankie, and I all have or had CPVT. So yes, I have it too. And I never knew that. I don't have a history of any cardiac arrest, but I have passed out several times throughout my life. And more so than just the passing out, I feel like I'm going to pass out often. I think I just learned how to pull it under control. You can imagine when we were told about our son passing, I felt like I was going to pass out. When Sammy was in the emergency room and they were working on him, same feeling. But I've just learned how to, I don't know another way to say it, to like steady myself. I take a deep breath and I sort of steady myself. I don't know if that does anything, but it seems to help me keep from passing out.
I bet Dr. Miyake could comment on that, but just in my sort of layperson view, I'm not a cardiologist. I wonder if it's, reducing the adrenaline rush that she's feeling. And I don't know. Do you have thoughts, Dr. Miyake?
Yeah, thank you guys so much. I asked you guys to be involved just because you're a remarkable family. You're so well spoken, and you have a story that's incredibly important to share that you can really teach. And I really think you didn't get to hear much of Sammy for those that are listening, but I have. And what strikes me about Sammy is just how involved he is in his care and his diagnosis. He's right there. He asks questions he wants to know. And that, for someone, from what they were told, from what the family was told, wasn't going to make it through the night, that's just a miracle. It is an amazing story. I love being part of this family and having a chance to be part of your care, but it's a difficult one, and that's why they're here. And here's one of the first questions: why does a family with CPVT have such severe manifestations, potentially, in one, maybe two children, Mrs. Burko doesn't really have the same findings. So this is one of her big questions. It's something that we are, I know that we would love to be able to give her a definitive answer. I can tell you that in some of my families, it is a highly penetrant disease for these, just meaning that for the most part, if you have the gene, most people will have some type of symptoms from it. I do find that we have some families who don't have any symptoms, and they tend to be more chill, to be honest. They tend to be family members who, or individuals who said, hey, that exercise didn't make me feel so good. Maybe I shouldn't exercise. And they just didn't exercise. They're very, very also, I don't know if this is a self-weeding, but they tend to be a little bit more, again, what I said, chill. Mrs. Burko, I don't know that I would describe you. I think as an avid athlete, you are on top of everything. So I think she is an outlier. I do think that she has something to teach all of us. And I think one of these days we will understand there's a lot. Many of you who do genetics, we do know that there are things that potentially modify what someone's quote phenotype is, whether it's environmental modifiers or epigenetics. These are things that can affect the actual gene change. We don't know, but that's really something that I think we need to learn more about. And we're still working, right? And to understand this more. But if anyone out there has any thoughts I know that these are things that the Burko family or that everyone wants to have answers for. So if anyone else wants to answer.
Thank you so much. Yeah. Let's go to some of the questions. I think we have 2 right now. Hopefully we're supposed to end around 8:15, so we'll hopefully be able to answer at least those. And if you have more, please put them in the chat. So one question, how do you decide to treat with ICD in cases of CPVT? Since it could also cause arrhythmia, the exact question that kind of Mrs. Burko had mentioned. We kind of went over this, but maybe you want to go over it again? Or
I didn't go into detail about this because this is really kind of the nitty-gritty detail, but a really important question. So exactly, the problems or the complications with ICDs is that, number one, the arrhythmias in CPVT tend to come and go. They burst, they come, and that can often trigger an ICD. The ICDs are programmed in ways that aren't great, in particular, often for CPVT. They're gotten better. I'm going to tell you that historically they were much worse. They've gotten much better now. But one thing is that sometimes they can inappropriately recognize or accidentally recognize a rhythm that actually isn't a life-threatening one. So one that is more stable, like I showed you the bidirectional VT, it shocks for that, and that releases adrenaline. So now you've had a rhythm that could have stopped, but now you've triggered adrenaline, and now you've got the rhythm even in a worse place. So that's one of the concerns. The other concern is that the device, and we've talked about this with the family, the device, if the rhythm doesn't stop, it will only go 6 times. If the rhythm stops, then you count over again and the ICD will work. So then how do you decide when to use it? I would say an example is the Burko family. It is a shared decision. For some people, it's a comfort having something at least as a backup. So I think that needs to be taken into consideration, particularly in this day. If you have an understanding of the rhythm and you can program that device in a manner that is more appropriate for this particular disease, you do need to consider what disease you're programming for. I think it's an option. I think that in general, we typically save the ICDs for those patients in particular that are non-compliant in essence. So if you've got someone who is not taking their medicines at all, they're at high risk. And you may be better off having that to save their life than to have nothing at all there to protect them. So I would say for me, and this may be different, it's particularly those patients where they do not take their meds. And so the medications I've seen have been relatively good at preventing the rhythm. But in this case, as you can imagine, and Jennifer and Craig, you may want to comment, but that safety or that having something as a reassurance, even if there are potential complications, can sometimes, be a choice. Important choice.
Our thought pattern on it, if you just want to know our opinion about why we might get the ICD for him, is because we lost our first son and we were told, you'll know if it works when it works, when he was given the seizure medicine. Well, unfortunately, with this disease, it's kind of the same question when you say, hey, is the medicine going to work? Is the sympathectomy enough? The answer is, we'll find out. Well, to us, we've already found out once. We don't want to find out again. So it's more of a reassurance thing for us to at least have something there. And we understand the risk and hopeful that the beta blocker, the calcium blocker, or calcium channel blocker, and the sympathectomy all work together to avoid, if he does get an inappropriate shock, and an inappropriate response to that shock, causing him to go back in. But it is a risk, and we haven't decided one way or the other fully yet. We're just leaning more towards the ICD. But
And Sammy actually has thoughts on it, because when we talk about the ICD, what was your first concern?
Then I would like,
He was concerned about he's concerned about the pain. And so one of the things that I failed to mention before is when you have a kid who has CPVT and they're fearful of having an ICD, fearful of the shock, that's a concern for me, because one of the things that I've noticed, at least with Frankie's case, our younger son, was each and every time, I believe it wasn't just adrenaline, but it was fear-induced adrenaline. And I don't know if that makes a difference scientifically, but it is one of these like minutia details that I've noticed, that we've all noticed. It was always fear. And I do believe that when Sammy looked down from the top, he doesn't love heights, but he handles them. And so I think when he got up to the top and looked down, he had an adrenaline rush that was fear-induced at the same time as a palpitation, which is what caused the cardiac arrest. I can't speak for myself. I don't know. But I know for my two children, I do believe it's fear-induced.
I just think this is an important point, in that as we continue to take care of families, that we as physicians really listen to them. Even if we as physicians don't feel that the ICD is, an appropriate management, if it's a potential, I think we need to hear them out. And I think that was a really important point to their story, and very, very valid point.
All right. Let me give you one more question. We'll do one more after this if we have time. We had an interesting question from Dr. Belmont, who's a geneticist. He mentioned, and this is something I was thinking about too, if we could use genetic testing to screen babies or children for inherited arrhythmias, would you be in favor, Dr. Miyake, or do you think it might be too worrisome to families? I was thinking, it would be great to catch it early, but then you run into the variants of uncertain significance, which is probably what you can talk about.
Well, I just want to thank, I haven't seen Dr. Belmont for a long time. He's not just a geneticist, he's an amazing geneticist, and a very, very valid question. And I think a difficult one. I personally think it kind of depends on the disease. So one of the worst things we can do is provoke unnecessary fear. And the problem, and I think Taylor's on too, is that in some of our diseases, for example, ryanodine receptor, which is one of the largest genes in the body, we get a lot of variants of unknown significance. In other words, we don't know. And I don't think that that's so helpful, because you really need to make the decision when you have the phenotype. So I think the hardest is CPVT, although I'm not against it. I think that it have to be pathogenic. In other words, you can't release results unless they are truly known. Long QT, I think, is a different story. I think long QT is a little bit easier if they're pathogenic, but ryanodine receptor is a really tough one. We get so many variants. We actually wrote a paper on the number of incidental findings on variants of unknown significance, and how difficult if you don't have a high pretest probability, in other words, if you don't have a high suspicion for it, it is hard to, it's usually not a real variant. So a good question. I don't know, Dr. Belmont, if you have thoughts.
Unfortunately, since it's a webinar, he can't unmute or chat. Okay. But yeah, maybe we could take this conversation.
I do think, my gut says at some point, here's what my gut says. We need to do a lot more genetic testing. And as we get more data, then I do think it's going to be appropriate. Because if we can diagnose this early and identify those that are truly at risk, we can save lives.
Yeah. And I actually have a very similar question. We could wrap it up after this. This is from one of our genetic counselors. So she said, thank you so much for this presentation. It's really helpful. If you have a patient that has more than one variant, whether they're both pathogenic or disease causing or not, that doesn't clearly segregate in the family with a suspected arrhythmia. That is to say, the people with the variant don't necessarily have the arrhythmia. How does that influence treatment or the specific diagnosis that's given?
Yeah, that's another a really challenging part of our clinic, because there's two ways to think about that. Number one is that you can have the variant and not have the phenotype. So Mrs. Jennifer Burko is potentially an example, right? She's got the gene, but she doesn't have necessarily as severe of a phenotype, although she does, maybe have some symptoms. So it can be very, very challenging. And if Taylor's on, we can give you some examples where we really, really have to spend time with that family and look for the phenotype. And sometimes that's watching them over years. To me, it is, you have to be sure. So you can't just take it at face value. So even if it takes you years and you need to pull in more genetics, more patients, really clinically phenotype them, then that's what we need to do. I don't think you can say it doesn't necessarily segregate, because again, you might not have obvious phenotype in certain genotype positive families.
Yeah.
All I can say is it takes a lot of, like I said, detective work.
Yeah, it sounds like it. And I think there's one more question that came through that I think is really interesting, and then we'll finish. So this is somewhat related to Dr. Belmont's question, but kind of a different take on it. Would postmortem genetic testing for inherited arrhythmias be done routinely in case of sudden unexplained death of a child?
That one I can answer. I think if a child has had a sudden death, that is not normal. These are healthy kids. If you die, then you're more likely to me to have a genetic cause than if you're a 60-year-old, adult with other high blood pressure. I personally believe that every child that's had a sudden death should have molecular autopsy or genetic screening. I think in this day and age, it can be helpful, and that's what we're working with the medical examiner. But I wish it was mandated.
Yeah, well, here's hoping we can talk about that at your next evenings with genetics. Although, hopefully other happy topics as well. So I think I want to be respectful of everyone's time. So we'll wrap up here. Thank you so much again to the Burko family for their really moving story. And thank you to Dr. Miyake for a beautiful presentation. I think Gladys has just a few things to wrap up, and then we'll be finished.
Yes, thank you all for sharing your story and your knowledge. Is definitely something that we can all take away from and really spread the message and be aware of these types of illnesses and hopefully do better. And so I do want to ask everyone to complete the survey. We do have an English version and a Spanish version, and so we'll just keep this up for just a second in case you want to screenshot or get your phone and scan the QR code. This information will also go out in an email tomorrow for those of you that registered on Eventbrite, and then that way you can have those links ready to go and be able to do the survey. It only takes a few minutes and it really helps us out. We want to hear from you. We want to get your feedback. It is important so that we bring presentations that are impactful to you and to this community. Our next Evenings with Genetics will be April 11th, 2023 at 7 p.m. via Zoom. And we will be talking about demystifying schizophrenia, a comprehensive overview of genetic risk factors and evidence-based treatments. And so we will have two different doctors on here, and we will focus on schizophrenia, which is a complex and often debilitating psychiatric disorder that affects 1% of the global population. So there's the QR code for that. And the link and this will also be on that Eventbrite email tomorrow. So hopefully you can join us for that one. And again, thank you so much for joining us. We really want to bring information to you that is useful and helpful. And thank you again, Dr. Miyake and the Burko family, for sharing your story and your knowledge. We really appreciate it. And with that, we'll close this Evenings with Genetics, and we will see you at the next one. Thank you.